Okay, for this module's Laboratory Interpretation Clinical Pearl, we're going to go over Cyrix Array 14, or the mucosal immune reactivity screen. And this is really an overlooked profile that can be very helpful in your practice, and it's a saliva test. And I can tell you that I was on the scientific advisory board when Cyrix was developing this test, and I was able to play a role in which markers were screened for, and I can give you some background information about the test itself. Now, many of the immunological testing that's done is done with blood. However, saliva is a totally overlooked tool when it comes to looking at different types of immune responses. And when you're looking at the mucosal immune response, saliva IgA may be actually one of the best ways to really see what's happening with that mucosal antibody response. Now remember, with antibodies you have IgG, IgM, IgA, and saliva, and in the mucosal layer, the main immunoglobulin is IgA. Now you still have IgG, IgM in saliva, but it's predominantly IgA. And then in blood you still have IgA, but it's predominantly IgG and IgM. But all the three antibodies exist in both blood and in saliva. Now you should also know that saliva IgG, IgM, IgA levels don't always correlate with serum levels of IgG, IgM, and IgA. And you should also know that if you're doing like cortisol salivary profiles with labs, and I'm not going to mention the specific labs, but with many of these labs that do cortisol profiles that include the secretory IgA, but they're not collecting the right samples, so you're always going to see depressed secretory IgA. And if you're doing a lot of adrenal salivary profiles in your practice, and all you see is low IgAs, and you've never been able to get them back up, it's really because the lab is not collecting samples in the proper vials. So what you'll notice with Cyrix Array 14 is the vial for saliva collection has different reagents, which makes it stable so you can accurately measure IgA. Labs that are measuring hormones like cortisol throughout the day, and they use the same vial without any specific reagents in there to stabilize IgA, are always going to give you a false low reading. So don't let your S secretory IgA levels that you're seeing with different hormone saliva tests throw you off of that. Their immune system is so compromised that you can't see clear an antibody test. All those labs need to include an additional correct vial for checking immunoglobulin A, which they have not done. Now, let's talk about this test itself. So the way this test works is the patient collects a saliva sample, and it's going to test for a series of markers. And you can see there's a whole bunch of markers that's being tested for with this profile. And this is such a great screen to see if they have intestinal permeability or reactions to the most common food proteins: gluten, wheat, soy, egg, corn, milk proteins, aflatoxins, like mold, gut reactions, mucosal reactions, and then to some heavy metals, rotaviruses in there. Rotavirus is a virus that's been shown to trigger celiac disease, and then some antibodies to myelin basic protein, blood barrier proteins, and immune complexes, which is another way of looking at general proteins where there's any degree of immune reactivity. Now, if you're doing saliva testing in your office already with like adrenal profiles, this is a really good test to add in as a evaluation. Now, some will say this is a screening test, but this isn't necessarily a screening test. IgA is a very reliable marker that can look for different types of reactions. When IgA levels of gluten have been studied in celiac disease population, they find them to be extremely reliable and very comparable to serum levels of gliadin antibodies. Now, there's a chart here that I included in the PowerPoint, so you can make sure you're familiar with all the different markers that are being tested on this profile. So the first thing you're going to check here is you're going to see, well, number 2 and 3, glutenzone and lactomycin. Those are the tight junction proteins. So if these are broken, you know that they have intestinal permeability. Or to say differently, if these antibodies are high, you know they have intestinal permeability. Now with all Cyrix profiles, you'll see they'll have like a range for green, which is normal, yellow, which is equivocal, which is one standard deviation above the normal population mean, which you have to consider clinically relevant. And then red, which is 2 standard deviations above the population mean. And they list that underneath here on all the reports to really explain what those are. But, any immunological antibody, even 1 standard deviation above the mean, is clinically positive. That's why they have this equivocal range. Okay. Now, if you see occludin or actomycin antibodies, then you know that they have intestinal permeability. So the next thing is to really see, do they have lipopolysaccharides? Remember, gram-negative bacteria in the gut release lipopolysaccharides, and if you have lipopolysaccharide antibodies in combination with leaky gut, that's where you have the intestinal permeability endotoxemia, which is the worst outcome of leaky gut. And that's where LPS can bind to things like toll-like receptor 4, TL4, and cause inflammation throughout the body. So this is the concepts we talked about in the cross-resistant gastrointestinal course. So the very first part is really just checking to see if they have intestinal permeability and if they have an endotoxemia with it. And then you get into ASCA-ANCA, which is a marker for Crohn's, ulcerative colitis, to look for intestinal autoimmune reactivities. So it's just a very quick screen. As you know, some people have chronic gut issues, really have intestinal autoimmunity. That's why they may not get better. And in the Cross Institute gastrointestinal course, we had a whole section of chronic gastrointestinal conditions, and one of them being intestinal autoimmunity. And knowing that will help you not have unrealistic expectations where you would expect to just do some dietary interventions and have their GI symptoms completely resolved. People that have intestinal autoimmunity have ongoing gut issues, so that'll help you see if that's a different factor there. Calprotectin is just a marker for intestinal inflammation. The higher the number, the more inflammation they have. So that'll check for that as well. Transglutaminase 2 is the laboratory marker for celiac. There are studies published on transglutaminase 2 saliva measurements being very reliable to identify celiac-related patterns. And then just for markers for gluten sensitivity, alpha-gliadin, gamma-gliadin, glutenin, those are all really important. And then wheat germ agglutinin. Now, transglutaminase 2 is letting you know that this isn't an antibody response to their actual self-tissue protein. It's an autoimmune marker. And with those that have transglutaminase 2, that's different than just having antibodies to gliadin, because transglutaminase 2 is reflective of a celiac immune response, which means they have an exaggerated T cell response, and they're going to have a severe inflammatory reactions when exposed to gluten. Now, if they just have gliadin antibodies, gamma-gliadin, glutenin, alpha-gliadin, these are different branches of the gluten protein, and they don't have transglutaminase 2, then they have gluten sensitivity. If they have transglutaminase 2, then you're thinking they have really more of a celiac disease or an exaggerated T cell pattern. Now, wheat germ agglutinin is really important. Those are the lectin portions of gluten that may cause reactions with people. And some people that have severe reactions to gluten don't have celiac or gluten sensitivity, but they just have reactions to the lectin, the sticky, sure protein portion of the wheat protein that's really causing a problem. And then gluteomorphin and caseomorphin are looking at different opioid proteins that are impacted in gluten and milk proteins. So people that have gluteomorphin responses will typically sometimes feel worse and have their gut dysfunctions exaggerated when they eat gluten-free for a period of time. It's almost like an opioid withdrawal. So be aware of that. Caseomorphin is a similar thing when people go off milk. They may notice that their symptoms are worse when they have these caseomorphin opioid type responses. And they'll be like, hey, I was doing better when I was eating gluten and milk. I didn't have the GI symptoms, and now that I'm off them, I'm much worse. And it's just like someone having an opioid response. When they go on withdrawal, they feel worse. And if they can just give it some time, they'll start to function and have their symptoms resolve. So you're always suspicious of adverse reaction or paradoxical response to gluten and dairy if their gluteomorphin and caseomorphin antibody markers are pretty high. And then the second part of this is just looking at the individual proteins, alpha, beta, casein. Those are the different proteins of milk. Egg protein, soy protein, corn. These are the most common food sensitivity reactions that occur, and they're found in many foods. So, egg albumin is a very common food ingredient, and many people that have autoimmunity, intestinal permeability react to these proteins more than anything else. Corn is totally way up there. Corn and soy, the GMO proteins, have become very immune reactive to people, so those are listed in there. Aflatoxins are dietary mold species. It may be an exposure to mold that's pathogenic for them, or it could just be a mold that's in some foods. Any kind of foods that are stored in bins will have some mycotoxins in them, some aflatoxins in there. So you got to be careful with jumping into a whole mold diagnosis with it. But for sure, they're probably eating foods that do have some mold species on there, and if they are mold sensitive, that can be a factor. And then we get into some chemicals here. These are not the actual amount of chemicals in their body, but if they're having mucosal immune reactions. What do we mean by that? I mean their gut mucosa, their nasal mucosa, their lung mucosa is having reactions when they're exposed to these proteins. To these chemicals. And these chemicals, what they do is they bind to proteins, and then they can become antigens. So bisphenol A plastics is the major one. And then mercury, mixed heavy metals. Mixed heavy metals is just a combination of different heavy metals. I believe it's lead, mercury, a couple other metals. You can see on their brochures if you go to the site, see exactly which ones are on there. But it's just any kind of heavy metal reactions that may be there. Again, these chemicals or markers, bisphenol A, mercury, and mixed heavy metals, are not levels that are high, but mucosal immune reactions to them. You could actually have someone who doesn't have very high amounts of BPA, but they're having immune responses to BPA. If someone has a bunch of mercury in their mouth, they may not have high levels of mercury in their blood, but they could have their mouth mucosal immune response against that. That could be driving their inflammatory condition or their autoimmune condition or something along those lines. And then myelin basic protein just looks for antibodies against the nervous system, but remember, it could just be against the gut nervous system. Many people that end up with chronic SIBO or have chronic intestinal inflammation that never resolves, and especially those that lose their enteric nervous system contractibility, where they can't move foods, and get chronic motility issues and constipation issues. They may have this autoimmune antibody response against their proteins in their gut nervous system, and this will help you identify those. And then blood-brain barrier proteins, the tight junction proteins of the brain, and then rotavirus, it's just a virus that can induce gut inflammation, and then just general immune complexes. And immune complexes, you definitely want to start thinking about like lectin, food sensitivity. Those are the main reactions to these immune complexes that are measured on this profile. So those are the main markers. So here you can see some examples of this profile. This is an ideal response, where everything is in green, everything is within range. And whenever you see everything within range, you just want to make sure like their actual levels are not really low. Like you can see this example is 0.1 to 1.6. They're at 0.81, which is right in the middle. This one's like 0.2 to 1.6. It's 0.85. Now if you saw this was, 0, the range is 0.1, they're at 0.2, you might suspect they may have a weakened immune response. You may have some false negative tests, but if everything looks healthy and green and there's nothing that's abnormal and their antibody responses are, pretty good in between these ranges, then you have an accurate response. The other thing I want to point out too is that you can see that there's IgA plus IgM, and the reason the lab did this, Cyrix did this, is because sometimes people have low IgA levels, and when IgA levels drop against the protein, IgM levels go up. And they found that they can get much more reliable results when they check these different proteins with IgA and IgM antibody complexes. And that's why they developed the test. So they individually did test IgA in saliva, IgM in saliva, and they found that the IgA plus IgM immune antibody response was the most stable and most sensitive response they could check. That's why you'll see IgA plus IgM. Now here you can see some really terrible outcomes here. You can see a person, for example, here you can see they have occludin, zonulin, and actomycin antibodies, which means they have leaky gut. Even worse than that, they have lipopolysaccharides high. So this is the classical leaky gut with endotoxemia. This is where the bacterial postbiotics get into systemic circulation when they have leaky gut. That causes severe inflammation throughout the body. And you can also see they have some ASCA-ANCA antibodies, which is an indication that may have Crohn's or ulcerative colitis. And for this one, like when you start to suspect they have Crohn's or ulcerative colitis, you definitely want to make sure they get endoscopy evaluations, and even serum testing just to make sure that this diagnosis is accurate. So it's always when you start to diagnose things like an autoimmune disease or even celiac disease, you want to do other follow-ups to really confirm the diagnosis. These are just antibodies to IgA, IgM against these different tissue proteins. So they have leaky gut, endotoxemia, potential intestinal autoimmunity happening. Their wheat germ agglutinin is high, so they're reacting to the lectin portion of wheat very, very seriously there, significantly there. So they could do much worse with sprouted grains, for example, because of the lectin content of sprouted grains. Their alpha toxin a little high, so this could be some things in their food that they're reacting to, but they're having immune responses to, alpha toxins in foods, which you definitely want them to avoid foods that are stored in bins or in bags for long periods of times. And then some chemical reactivities, and rotaviruses, you'll see this sometimes. It just means this could just be a past infection, and sometimes it's just triggered by the chronic inflammation. There's not much you necessarily do for that. You really want to go after and treat the leaky gut, remove the food proteins, see if you need to manage your autoimmunity in more detail, and see how this pattern changes over time. Here's another example. Here you can see like a mixture of things. Some are in the clearly 2-year standard deviations out of range, some are equivocal. So very similar, you can see like intestinal permeability with endotoxemia, leaky gut with endotoxemia, some inflammatory responses there, definitely some gluten sensitivity issues, but not necessarily celiac, some opioid reactions to gluten, so you have to be very conscious of the fact that if they do go gluten-free, they may have some paradoxical reaction where they feel worse for a period of time. Corn aflatoxin reactions, some chemical immune reactivity reactions, even some issues where their enteric nervous system may be impacted. Like this was a patient with SIBO, you're concerned about chronic inflammation and some autoimmune target proteins of the gut nervous system potentially being impacted, even concerns about the blood-brain barrier. So they have a leaky gut barrier, leaky blood-brain barrier, endotoxemia, reactions to gluten. There's a lot of information you can pick up with this saliva test. So I'd really encourage you to look at this mucosal immune reactivity panel, especially if you have patients that don't want to do blood samples or if blood draws are becoming difficult to you, and if you're already using a lot of saliva tests in your office anyways, this could be as important to hand out every time you hand out like an adrenal salivary profile, to really get a big picture of what's happening with your patient's mucosal immune response. Remember, the mucosal immune response is the gut barrier, the pulmonary barrier, the mouth, the sinuses, nasal area. These are the different reactions that may be occurring with these IgA plus IgM complexes. I hope you found the information helpful. Thank you.